Hi. Well, today is the first day of my actual radiotherapy, radiation therapy for my prostate cancer. So I wanted to sort of check in and let you know how I'm feeling and what's ahead. Of course, I'm a little bit nervous about this. It's the first time in my life I've ever had this much radiation. I've avoided radiation sort of like the plague for all these years. Wouldn't even allow my dentist to do dental x-rays sometimes. So now I'm going to be hit with a whole lot of radiation to a very vital area, which is the prostate. And I think it's a justifiable decision. I was a little bit thrown over the weekend by reading a paper from 2 years ago in the New England Journal of Medicine, and I'll reference that paper. But basically, it was a well-done study from the New England Journal of Medicine and came out of the University of Oxford, a highly regarded center, to put it mildly. And in fact, there were many co-authors on the paper from all over the UK. And basically, it showed that there wasn't much difference in terms of survival between people who got radiotherapy or surgery, prostatectomy for the prostate cancer, or active maintenance or active surveillance. So those people who got the active surveillance basically were getting PSA tests done every 3 months, and they had to see their urologist and sort of watch their PSA rise. But most prostate cancer is so slow growing, and this study had a lot of elderly men in it, that in the end there wasn't that much difference in terms of the actual survival. So that was a bit of a shock. I mean, I think most of us think of cancer treatment as being a way of extending your life. And statistically speaking, there didn't seem to be much difference among the 3 different approaches to the disease. This disturbed me a little bit, but then I read a little bit closer into the study, and what it did show was that the rate of metastasis was double in the people who only got the active surveillance or maintenance as opposed to people who got either surgery or radiation. So I'll simply summarize by saying that the rate of metastasis or outside spread of the cancer outside the prostate gland was about 9 or 10% in the people who were under active surveillance, as opposed to about 5% in either the surgery or the radiation. And across the board, there really wasn't much difference in outcomes between those who had surgery and those who had radiation. So, you could make a case for either of those 2 approaches, and part of it would depend upon your age and your comorbidities, as they call it, other diseases. So I think that lack of metastasis would be reason enough to submit in many cases to have the kind of treatment that I'm going to have. So I found that reassuring. It gave me, after a bit of a hesitation, it gave me a clear rationale for doing what I'm about to undertake, which is to have 44 sessions of radiation over the next 2 months. Not everybody would agree with that because of the lack of clear survival advantage. But having lost some friends, dear friends, to advanced prostate cancer, having seen what that means in terms of the overall experience, metastasis in prostate cancer generally goes to the bones. This has been known for like over 100 years. And so bone cancers tend to be very painful. And I think the overall experience, first of all, you'll have about half the chance of getting that kind, distant metastases. But You'll also avoid a prolonged period of anxiety as you watch the PSA rise, maybe slowly at first, and then, of course, it can get into very high numbers. And I've counseled and talked to many, many patients who have gone through this situation, so I try to avoid that. But it's interesting to look at the science of it. And I've also been looking back at historical texts that I happen to have. I have some wonderful old textbooks from the 1930s and 1940s, and what a difference, a century or 80 years or whatever makes. Well, for instance, looking back, I have a 3-volume textbook that was mainly written by people at my old alma mater, Memorial Sloan Kettering. And in that textbook, there are 2 chapters on the treatment of prostate cancer, one of them written from Johns Hopkins. And interestingly, I didn't remember this or realize this, that the Halsted radical that's so notorious in the treatment of breast cancer, that kind of radical operation was also done fairly commonly, mainly at Hopkins and a few other places, for prostate cancer. So they were removing not just the entire prostate gland, but many areas and organs around the prostate, parts of the bladder and so forth. I mean, they just were being very radical, very extensive in terms of the surgery, but with little indication that actually did anything in terms of people's survival. It certainly must have diminished the quality of life of the people who got that operation. So I think it's just another example of why we need clinical trials, because oftentimes something is quote unquote logical, but not really that effective. And you have to eliminate treatments that are not effective. So I think that I feel justified in doing the treatment that I'm going to undertake. Maybe I'm talking myself into it, but I think it may not actually extend my life, but also you have to think about the overall consequences of a treatment. And the other big issue is that, given my case, I think it would be has been recommended to me several times, that I also have hormonal treatment, androgen deprivation therapy, or ADT. I've chosen not to do that, even though I recognize that the numbers in terms of recurrences are somewhat better if I were to do that. But if it was as simple as something taking a supplement or taking a vitamin or something like that, well, I would do it. The problem is that the side effects, the common side effects of ADT, are exactly the things that I'm trying to avoid in my life otherwise. In other words, the metabolic syndrome increases with ADT, your weight goes up, your ability to handle glucose, and your propensity towards type 2 diabetes. I have all of those things. And I've had them for longer even than I've had this prostate cancer problem. So I can't see, it would be robbing Peter to pay Paul. I would be probably getting statistically some benefit from doing the ADT, but on the other hand, what would be the point if it could actually increase my risk of heart disease and serious consequence of diabetes? I've managed my diabetes for 11 years now, just with diet and exercise, walking, vigorous walking, and so forth. And it's been pretty successful in the sense that my A1C test is in the high normal or slightly pre-diabetic range, and my weight is under control and so forth. And I can't see ruining my health for the purported benefit of a lack of recurrence of the disease. So these are my thoughts as I'm about to go into the first session of what's going to be a 2-month adventure with radiation therapy. Anyway, I'm not scared. I'm feeling optimistic. Looking forward to it, going through it. Everybody's wonderfully nice in the facility that I'm going to. And I also wanted to say that we've had quite a few views on the other videos that I've done, and I had numerous well wishes from both people that I have known over my career and also strangers who have, come to my website, my readers, my viewers, and so forth. So I want to thank you all for that, and many very thoughtful and wonderful suggestions people have made to me about my own situation and my own treatment. So it's very heartening to have so many friends and people rooting for me. So thank you again. So till next time, this is Ralph Moss.